Good evening, everyone. I'd like to welcome you to this very exciting program this evening on MASLD. We have a terrific program with the best experts here at Cleveland Clinic to speak to you about some incredibly important topics. For the next hour and 15 minutes or so, you'll hear from a multidisciplinary team from Cleveland Clinic. It's a very timely topic, as many of you can tell, that there are nearly 900 healthcare providers registered for today's event from 80 countries. And so we're very pleased to welcome all of you from all across the globe to this very special program. Please feel free to use the chat to tell us where you're from or to tell us what your practice is about, as well as to ask any questions. We're very pleased to have received educational support from multiple industry sponsors. And so many thanks to Cook Medical, to Janssen Biotech, to Medtronic, and the Olympus Corporation of the Americas for their very generous support for today's program. And with that, without further ado, I'd like to introduce my fellow co-leader for this course and our leader for the obesity task force here at Cleveland Clinic, Dr. Sobia Like. Sobia?
Thank you, Dr. Kim. So we're very excited about today's session and really have put together a phenomenal faculty for you today with experts from various different fields. So to get started, we have Dr. Ali Aminian, who is the director of our Bariatric and Metabolic Institute. We then have Dr. Mazhar Khalil, who is one of our transplant surgeons with a specific focus in obesity management as well. To follow, we have Dr. Yael Mauer, who wears multiple different hats throughout the Cleveland Clinic enterprise, but most noticeably has a very prominent presence with our Primary Care Institute, and then is also the co-director for our multidisciplinary MASLD clinic. Next, we have Dr. Salvador Navarrete, who is a metabolic surgeon by trade, but also has co-led the development of our concurrent liver transplant and sleeve gastrectomy program. And last but not least, we have Dr. Karen Zhou, who goes by Kathy, and she is the phenomenal research director for our endocrinology group. And so with that, we will then get started. And we actually have Dr. Zhou presenting first.
So it's my great pleasure to be here. I have the privilege of speaking to you about one of my favorite pharmacologic therapies, essentially the incretin therapies, and how they may have a new role within the MASH ecosphere. So I think it's really important to kind of reflect on this particular slide, which some variation of many of you online may be familiar with. So this essentially shows the progression from MASL to MASH, and then MASH with fibrosis, and then of course cirrhosis and beyond. And I think that it's important to understand that it's not just the liver disease that you are managing for this individual. It's the concurrent, cardiovascular risk. We know up to 75% of these individuals have diabetes. There are higher risk for other malignancies. And so the care of an individual who has MASH, MASH fibrosis, MASH cirrhosis really is a multidisciplinary approach. And you'll get to hear, of course, as Dr. Lake already said, from many different experts in their own spaces, all of whom come together to provide support for these individuals. So we'll start with the question of what exactly is a GLP-1. So this actually is a hormone, hence the endocrinologist speaking to you, that's produced from the L cells in the small intestine, and they have a plethora of different effects within the body. I think as an endocrinologist, I often think about it as a reduction in glucagon production, improvement in insulin production, and then an improvement just broadly in insulin resistance across the entirety of the body, in addition to a significant number of cardiometabolic benefits, which many of you may be familiar with. There's about 7 different versions of GLP-1 receptor agonists that are available here in the US. I know many people are maybe joining from other places that are available to treat type 2 diabetes, and I've displayed them here along with their relevant available doses. However, when we turn our attention specifically to weight loss GLP-1 receptor agonists, it turns out that there's only 3 that are currently available. Saxenda, which is liraglutide, Wegovy, which is semaglutide, and then, of course, Zepbound, which is tirzepatide, and, of course, displayed here with some of their relevant dosing strategies. It's important to understand that there is a distinction in terms of the approvals for weight loss or type 2 diabetes when you're considering therapy, for example, for your patient. For example, if they do not have a diagnosis of type 2 diabetes, you will then be sort of restricted into this group of 3 agents. In turning our attention now more specifically to MASLD and MASH, how is it that GLP-1 receptor agonists are able to induce an improvement in this pathology? And it turns out it's by a number of different ways, to no surprise of anyone. We reduce insulin resistance at the level of adipose tissue, we reduce lipolysis, inflammatory cytokine levels, and adiponectin is increased, which is a protective hormone metabolically. At the level of the liver, you get an improvement in insulin sensitivity, a reduction in glucose production, and a reduction in also various cellular stressors. So the whole conversation around incretin therapies really in some ways took off with the publication of 2 phase 2 trials in New England Journal of Medicine in the summer of last year, one of which is this publication on survodutide, looking at MASH and fibrosis. And so thinking about survodutide in particular, what you can see in this schematic on the lower left-hand side is that this is actually not just a GLP-1 receptor agonist with all of the aforementioned benefits, but it is indeed a dual agonist. So it hits the GLP-1 receptor and also the glucagon receptor, and hence is thought to actually have this sort of synergy with the GLP by having the glucagon receptor agonism. So glucagon effect in the liver seems to be able to induce an increased energy expenditure, leading to a reduction in fat content, and also to lead to a reduction in activation of the stellate cells, which of course many of you are familiar with as being a core cell involved in the physiology of fibrosis and MASH. In this particular trial, phase 2 trial, they enrolled individuals with MASH and fibrosis stages 1 through 3, and their primary endpoint was to see an improvement in MASH, which they defined as greater than a 2-point decrease in the NAFLD activity score with no worsening of fibrosis. And this was after about 48 weeks of treatment with one of 3 potential doses of survodutide. And what you can see here in the middle table or graph here is that they actually met their primary outcome, and they were able to clearly demonstrate that survodutide can improve MASH without worsening fibrosis. They also saw a significant decrease in liver fat content by at least 30%. And notably, although it's not displayed here, 34% of the individuals in the group treated with survodutide 6 milligrams had actually at least a 1-stage improvement in liver fibrosis compared with only 22% in placebo. Turning our attention to tirzepatide, this was the other major publication in that issue. It was a pretty massive one when it comes to MASH. They also published from their Synergy NASH trial their phase 2 results. Tirzepatide, notably, is another dual agonist looking at hitting not only the GLP-1 receptor, but also the GIP receptor, thought to maybe improve kind of lipid metabolism in the body. how it works synergistically with the GLP action. In this particular study, the primary outcome was looking for a resolution of MASH and no worsening of fibrosis. So in some ways, an even more intense outcome than what I was just discussing with survodutide. And what you're seeing here is that every single dose of tirzepatide that was studied, 5, 10, and 15, met that primary outcome when compared with placebo. But that as you went up in the dose, that a higher percentage of participants in the study was able to reach that primary outcome. And notably, it's intriguing to see that many patients, a higher percentage of patients in the tirzepatide groups was able to see a decrease of greater than 1 fibrosis stage without worsening of MASH. Notably, this finding was not statistically significant, but it was sort of hypothesis generating and certainly of interest here. So in both of these trials, again, you met the primary outcome in an improvement or resolution of MASH with no worsening of fibrosis. And in both trials, you saw kind of this hint or suggestion that you're going to see an improvement in fibrosis as well. Moving on to our most recent publication just from a couple of months ago in April was our phase 3 interim analysis of the ESSENCE trial, which was looking at semaglutide in MASH fibrosis. And this was quite intriguing in that they were comparing the 2.4 milligram dose of semaglutide against placebo. And as I mentioned, it was an interim analysis of the first 800 patients to enter the ESSENCE trial with a total enrollment planned of greater than 1,100. And it was a week 72 analysis, so a fair bit longer than some of the prior trials that I was mentioning. I have displayed here, of course, some characteristics of the patients in this trial. You'll notice that they were not necessarily morbidly obese, kind of class 1, 2 obesity on average. As you might expect, a large number of them had type 2 diabetes over 50%, which is in line with both prior trials I displayed. And also fibrosis stages 2 and 3, geared a little more towards fibrosis stage 3. And in this interim kind of analysis of this phase 3 ESSENCE trial, you saw that a significantly higher number of individuals, higher percentage of individuals in the semaglutide 2.4 milligram arm met the primary outcome of resolution of steatohepatitis with no worsening of liver fibrosis, which you might expect. But what was very intriguing with this particular trial is that they also were finally able to demonstrate with statistical significance a reduction in liver fibrosis with no worsening of steatohepatitis. And bearing in mind that this is the first trial to very concretely show statistical significance for this. So let's turn our attention then to MASH cirrhosis. So what about MASH cirrhosis? And so it turns out that there has been some work done in this space. A couple of years ago, a trial was released looking at semaglutide 2.4 milligrams in those with MASH cirrhosis. It was a phase 2. Unfortunately, the trial did not meet the primary outcome of improvement in liver fibrosis without worsening of MASH, and also did not show any difference compared with placebo for resolution of MASH. However, having said that, there were a few very intriguing kind of findings from the study. The first being many of the patients had significant improvements in their metabolic outcomes. They lost quite a bit of weight. They had improvements in their A1C. And then additionally, there was also a significant improvement in liver steatosis as measured on MRI-PDFF. So almost 50% of the individuals on the semaglutide arm in this trial lost at least 30% of fat, or had a reduction, I should say, of at least 30% of fat in their liver, which was fairly substantial and certainly more so than what was seen in the placebo arm. So really the question here is not so much whether or not, the game over, right, for semaglutide in cirrhosis, but rather whether or not we should be doing a longer study. This was a 48-week trial with only 61 participants, so longer study, more participants, and would we actually have seen a difference in the two arms for the primary outcomes? Additionally, survodutide also has done a phase 1 study published last year looking at safety, tolerance in individuals with MASH cirrhosis as well. And what you can see here on the graphs that are shown is that there was a significant reduction. I shouldn't say significant, but there was a reduction that was seen in the survodutide arms compared with baseline for things like liver fat, liver stiffness, the enhanced liver fibrosis score, that blood test, and the ProC3 levels that would be suggestive that in their larger trial that they are conducting in cirrhosis, that they may be able to see a significant improvement in primary outcomes, and maybe some improvement in MASH and also MASH fibrosis. So in thinking about what to take home from this, I think it's to understand that GLP-1 receptor agonists will become a mainstay of MASH management alongside other therapies in the pipeline. And it's not only improvement in MASH, but also fibrosis. And I think the future, which is currently underway, is that GLP-1 RA will also have a role in cirrhosis. And I think for the hepatologists, GI docs on the line, consider familiarizing yourself with the prescription of these medications and counseling patients on them as it's coming down the pipeline. Thank you again for your time.
Thank you, Dr. Zoe. That was great. So moving on, we next have Dr. Ali Aminian, who's going to be talking to us about the evolving role of metabolic surgery in MASH.
Hi, everybody. So in the next 10 minutes or so, I'm going to talk about evolving role of metabolic surgery in MASH. Here's my disclosure. As a previous speaker explained, obesity is the main driver of the disease. So when we have obesity, fat infiltrates everywhere, including into the liver. And then over time, that can damage the liver. Inflammation comes, which is called MASH, and then scar tissue forms, and then scar tissue gets worse over the time. We have initially there is no scar tissue, then after several years that can progress to F1, F2, F3, get to the F4, which is called cirrhosis, and then in the beginning people don't have symptoms, it's called compensated cirrhosis, and then it may get progress to decompensated cirrhosis. Down in the road, people may develop liver failure or hepatocellular carcinoma, and that can be terminal. So since the disease starts with obesity and fat accumulation into the liver, so it makes sense to think about weight reduction as the mainstay of treatment in people with obesity and this disease. So I would assume that many of the audience are not surgeons, so I'm going to briefly explain the procedure that we do. So in terms of the name and definition, so these names, bariatric surgery or metabolic surgery or weight loss surgery, can be used interchangeably. They refer to the same thing. So these are procedures that influence metabolism by inducing weight loss and altering GI physiology. So in the United States and worldwide, 90% of the procedures that we do are either sleeve gastrectomy on the right side or Roux-en-Y gastric bypass. So on the sleeve, we get into the abdomen with 5 or 6 small holes with a camera, and we, with the help of this stapler, we cut the stomach, we fire the stapler several times, and we remove this part of the stomach, which is about 80-85% of the stomach. Surgery takes about an hour. Patient usually stay in hospital one night. They go home the next day. recovery takes 2 or 3 weeks. Risk of having all complications is about 3%. Out of 100 patients, 3 may develop complications, bleeding, infection, blood clot, everything all together. So 97% of patients won't have any issues. And over the course of next 8 to 12 months, they usually lose about 1/3 of their weight. So if they start with 300 pounds, they lose about 100 pounds. If they start with 240 pounds, they lose about 80 pounds. So we know that the individual response is different, but on average, people usually lose about 1/3 of their body weight with the sleeve gastrectomy. The bypass is more effective in terms of inducing weight loss and having metabolic benefits. So to do the bypass, again, we get into the abdomen through 5 or 6 small holes. We cut the stomach on the top part to make a small pouch, and then we bring the loop of a small intestine up and connect to that pouch, and then we make another connection here. And when patient takes food, foods go through the mouth to the esophagus to this small pouch, and then from here, it will be shifted directly to the small intestine. So we bypass about 95% of the stomach and proximal 100 centimeter of the small intestine. So again, it takes about 2 or 3 hours. Patient usually stay in hospital one night, they go home the next day. Recovery takes, like the sleeve, 2 or 3 weeks. People usually lose 20, 25, 30 pounds more with the bypass than the sleeve. Again, it's more durable, it's more powerful. So not surprisingly, with that large weight loss, durable weight loss, we can see benefit in liver histology. So here is finding of Braves trial, about 300 patients with MASH, and some of them had fibrosis, were randomized to 3 groups, and they had repeat liver biopsy a year after, about 100 patients in each arm. And the primary endpoint was MASH resolution without worsening of fibrosis. We see that surgical procedures outperform the medical management in terms of MASH resolution and in terms of fibrosis improvement. And there was no difference between the sleeve and bypass in terms of histology. So here's our data from Cleveland Clinic. Again, you see here, these patients had repeat liver biopsy on average 2 years after the initial biopsy, and about 2/3 of patients had either MASH resolution or fibrosis improvement, much better than the usual outcome. And if you consider both outcomes, MASH resolution, complete resolution of MASH, plus fibrosis improvement, at least 1 stage improvement in fibrosis, half of the patients who underwent bariatric surgery met that outcome, which is a substantial improvement in their liver histology. But patients don't care about histology. They want to see the improvement in their lives. They don't want to have complications of the disease. So in the Splendor study, we reviewed the outcomes of patients who had bariatric surgery with us at Cleveland Clinic in the past 2 decades, and we followed them longitudinally. And we compared them with patients who received usual care for their disease over the course of past 2 decades at the Cleveland Clinic. So all patients in the Splendor had MASH and liver fibrosis, F1, F2, F3, no F4. So 650 patients in the surgical group, 83% had gastric bypass, 17% had sleeve gastrectomy. So we had 2 composite endpoints. One is major adverse liver outcome, or MALO, which was defined as progression to cirrhosis. So all patients had F1, F2, or F3, no cirrhosis at baseline. So progression to cirrhosis, development of liver cancer, need for liver transplant, or dying from liver disease. And the second primary composite endpoint was major adverse cardiovascular event, or MACE. They had heart attack, stroke, heart failure, or dying from cardiovascular disease. So baseline, see exactly the same between the 2 groups. And in terms of fibrosis stage, 50% had stage 1 fibrosis, 29% stage 2, and 20% stage 3 fibrosis at baseline. So obviously, surgical patients lost more weight. They had better diabetes control over the course of 10 years. And here's the main finding. Over the course of 10 years, 2% in the surgical group progressed to MALO, which was defined as cirrhosis, need for liver transplant, dying from liver disease or liver cancer, versus 9.6% in non-surgical control. So as you see, surgery or the significant weight loss that comes with surgery could change the trajectory of the disease. Surgery was associated with 88% lowering the risk of MALO over the course of 10 years. How about MACE? Again, you see nice separation of the curves favoring the bariatric surgery. Surgery was associated with 70% lowering risk of MACE over the course of 10 years in people with fibrotic MASH. How about in patients with cirrhosis, MASH cirrhosis? And as you saw, Dr. Zhou presented the data of semaglutide that couldn't meet the primary endpoint in people with MASH cirrhosis in terms of improving liver histology. So we looked at the clinical outcomes of our patients who had MASH cirrhosis. Those patients had compensated MASH cirrhosis, and all were biopsy proven. And some of them had bariatric surgery, about 60 of them, and about 100 of them had received usual care. And we followed them over the course of 15 years to see what happened to them. And the primary endpoint was, again, MALO, which was defined as progression from compensated cirrhosis to decompensated cirrhosis, development of liver cancer, need for liver transplant, or dying from the liver disease. As you see here, again, nice separation of the care, favoring metabolic surgery. Surgery was associated with 72% lowering risk of MALO over the course of 15 years in people who underwent metabolic surgery compared with people who received usual care at Cleveland Clinic. Then progression from compensated to decompensated cirrhosis, and surgery was associated with 80% lowering risk of progression to decompensated stage. Obviously, surgical patients lost more weight, they had better diabetes control, and that was durable and persistent over the course of 15 years. So to summarize, indications of bariatric surgery in MASH, so any patients with obesity, BMI over 30, who has F0, F1, F2, F3, can be a good candidate for bariatric surgery. So that doesn't mean all those patients gonna be eligible, but at least those people need to be referred and need to be assessed for bariatric surgery. And bariatric surgery can change the trajectory of the disease, because as we discussed, obesity is the main driver of the disease. When we take care of the obesity, the consequences of obesity, including MASH, can improve. In people with F4 or cirrhosis, if they have compensated disease, and if they don't have portal hypertension, still can be a good cases or good patients with bariatric surgery. But if people have portal hypertension, we need to lower portal hypertension before surgery, before considering surgery. Otherwise, if we get in and if you fire the stapler on the stomach, that may cause profuse bleeding, and we don't want that, and that can be life-threatening. So in those cases, we usually place tips. We ask our interventional radiologists to place the tips to lower the portal pressure, and then after that, we can safely do bariatric surgery. So again, progression of the disease, we have a very long window of opportunity in people with simple fatty liver disease, with people with MASH, in people with liver fibrosis, even in people with compensated cirrhosis. We can consider bariatric surgery to take care of root cause of the problem, which is fat accumulation into the liver. If they have portal hypertension, then we need to take care of that. So you see here on the left side, this patient had esophageal varices, one of our patients. We placed the tip, we lowered the portal pressure, we confirmed that those varices are gone, and then we did a sleeve gastrectomy. The other patients, or patients who had hypertensive gastropathy, and then we placed tips, we lowered the portal pressure, we confirmed that, and then we did a sleeve gastrectomy. So contraindications of surgery in this population, obviously people who have decompensated cirrhosis, so these people are very close to liver transplantation and they need to be assessed for liver transplant. If patients have severe coagulopathy, patient with portal hypertension, we discussed that as a relative contraindication that can be managed by tips. Or if the patient had extremely high MASLD score, again, those are people who are close to liver transplantations. In terms of procedure selections, all procedures, sleeve or bypass, could be good choices in patients with F0 to F3, patients with compensated F4, who are sicker patients. Maybe a sleeve gastrectomy would be a better choice because they may need liver transplant in future. And if they undergo transplant, they usually need to have access to biliary tree with the ERCP procedures down in the road. So a sleeve gastrectomy might be a better option. So take home point, metabolic surgery is safe, is effective treatment for obesity and MASH, particularly in people with F0 to F3. And if patient had F4, that needs to be selected and compensated patient with F4 without significant portal hypertension. And that can lead to MASH resolution in over 50% of the patients, half of the patients, and lowering risk of MACE and MALO in long-term follow-up in almost 75% of the patients. Thank you very much.
Thank you so much, Dr. Aminian. Once again, another brilliant talk. So moving on, we're going to have Dr. Mauer now present on the multidisciplinary care models in MASH from concept to implementation. This has been an area that has been extensively talked about in the field about how different subspecialists need to converge together to provide comprehensive care to these patients. So she's going to highlight some of the stuff that we've implemented at Cleveland Clinic itself.
I want to start by thanking the organizers for inviting me to speak about this exciting topic and all of these exciting projects that we have going on at the Cleveland Clinic. I don't have to tell you, everyone here knows that MASLD is a growing problem, a crisis. MASLD affects 1 in 3 adults globally and is projected to impact over 40% of adults by 2050. It's a leading cause of cirrhosis, liver cancer, and transplantation in the United States. And it is a multi-system disease, and it's tightly connected to metabolic disease, as Dr. Zhou and Dr. Aminian already described. The main pathophysiology associated with fatty liver is insulin resistance and obesity. So as fat accumulates in the liver, fatty liver develops. And it does have a very significant economic burden, projected to exceed $250 billion by 2040. So what are the challenges in managing this very common, very serious progressive disease? Partly is a limited knowledge regarding optimal screening and treatment strategies. And another big piece is fragmented care, lack of coordination and multidisciplinary care models. And as we already discussed, fatty liver or MASLD is not really a liver disease, but a liver manifestation of metabolic disease. So having this coordinated multidisciplinary care is really what provides the optimal benefit for patients with MASLD. Another challenge that we're all familiar is access to pharmacotherapy and metabolic surgery for eligible patients with MASLD. So what was our solution? In 2024, Cleveland Clinic launched the MASLD Task Force. This is a multi-institute collaborative effort to foster interdisciplinary collaborations to improve prevention, early detection, and treatment of MASLD through the entire spectrum of the disease, from simple steatosis all the way to transplantation. And we want to improve patient outcomes. And we want to have a unified approach managing liver as well as cardiometabolic disease combined. So this is a little bit of a busy slide, but stay with me for a moment. I want to tell you how our multidisciplinary clinic works. Essentially, we get mostly internal referrals, but we also get external referrals. And we also do case identification through FibroScan reviews. And all of these patients are identified and they are scheduled centrally with our multidisciplinary MASLD clinic. And when they come to clinic, they receive evaluation from hepatology and endocrinology in tandem. And when appropriate, we are able to refer the patients and connect them directly with metabolic surgery. They receive diagnostic testing like FibroScan, CK, body composition testing, and lab testing, and so on. And essentially, we also have integrated support from dietitians, exercise physiologists, social workers, financial coordinators that help us put all of these pieces together. And subsequently, the patients are divided into different categories. For patients with at-risk MASH, we do cardiometabolic optimization, lipids, triglycerides, diabetes management, obesity management. We also do liver-directed agents as well. And we do metabolic surgery evaluations when patients qualify and they're interested, as well as enrolling them in clinical trials. For patients that have compensated MASH cirrhosis, we also offer the opportunity to join shared medical appointments. And this is a series of 3 monthly shared medical appointments. One focus on nutrition, one focus on exercise, and the last one focus on behavioral health, where patients receive brief counseling, screening, brief counseling, and then they're referred for additional therapy one-on-one. Of course, these patients also receive cirrhosis surveillance and clinical trial enrollment. And we are also looking at new pathways for patients with early decompensated cirrhosis, combine liver transplant with sleeve gastrectomy programs. Dr. Aminian talked a little bit about some of those opportunities. And also we're looking at transplant MASH recurrence in patients who continue to have metabolic disease after they receive a transplant. And we're also looking at liver donor obesity optimization. I know the lettering is a little bit small here. Again, stay with me. Once the patients are referred to the multidisciplinary MASLD clinic, for patients who have compensated MASH cirrhosis and obesity and are interested, we schedule them for the SMA, the shared medical appointments that I described a few minutes ago. The shared medical appointment number 1 is nutrition and dietary counseling. We do screening for the patients, things like we look at protein intake, portion sizes, and nutrient gaps. And they receive didactics by a dietitian, like protein optimization, meal timing, Mediterranean diet principles, and so on. We give them practical skills like how to read labels, and then they are referred for one-on-one personalized counseling depending on calorie needs, preferences of the patients, and so on. SMA number 2 is focused on exercise and physical activity. Again, we do some screening. We look at things like motivation for exercise, barriers, frailty, functional capacity. They receive brief interventions and didactics by an exercise physiologist. We talked about things like benefits of exercise, safe activity, and so on. And then the patients are referred to one-on-one personalized counseling with an exercise physiologist. And lastly, the last SMA is focused on behavioral health. Again, the screening, the didactics, there's also a group discussion component for this session. And then subsequently, the patients, when appropriate, are referred to one-on-one psychology sessions. And all of this is integrated with pharmacotherapy adjustment, liver and metabolic lab monitoring, and tracking of lean mass through body composition. And what are we going to be looking at? We're going to be looking at a lot of different things: cardiometabolic and liver outcomes, access and efficacy. We're going to be looking at patient engagement and experience, behavioral signals in healthcare utilization, and health equity and reach. So as you already know, MASH is among the top causes of cirrhosis and liver transplantation. The care remains fragmented, and that underdiagnosis is common, and access to effective therapies is limited. So our solution is to integrate the metabolic and the liver pieces, the surgical pieces. We created a MASLD task force, and we integrate liver and cardiometabolic care, standardized screening and diagnosis. There's a lot of pieces to the MASLD task force. We're doing not only patient care, but also screening algorithms, teaching other providers how to screen, how to refer, and so on. And we want to expand access to therapies and clinical trials for appropriate patients. The flagship model includes the MASLD multidisciplinary clinic that I just described to you. It launched in December 2024, so still very new. It provides integrated care, team-based care within hepatology, endocrinology, surgery, nutrition, behavioral psychology, exercise components, and it's focused on high-risk MASH populations. It also serves as a clinical trial hub. A lot of patients are recruited from this clinic. And we also provide the MASH cirrhosis SMA series, a 3-part series focused on lifestyle, pharmacotherapy, and behavioral support. And with that, thank you so much for having me today.
Thank you, Dr. Maurer, for providing such a comprehensive overview. So now we're going to move to the Q&A part of our session today. So we have some great questions that have come up in the chat box, and so I'm gonna throw them around for the panel, and anyone who pleases to answer, please go ahead. But I think this one's mainly for Dr. Aminian and Dr. Zoe. And so the question is, are there any upcoming or ongoing head-to-head studies comparing efficacy, short and long-term outcomes between bariatric surgery and the GLP-1 medicines, really looking at outcomes in terms of MALOs and MACE?
Well, that's a great question, and it's important those type of trials. But just to clarify, doing randomized clinical trial of surgery versus medication is extremely challenging. It's not like medication A versus medication B that people are keen to be randomized and willing to participate, or medication versus placebo. So some patients want the surgery and they don't want any medication, so you can't change their mind. And some people are completely against surgery and they only want medication, and you can't force them. So that's why those type of studies comparing surgery or any surgical intervention with any medical intervention, because these are too extreme in patient's mind and patient's view, are extremely challenging to do. So that's why it's going to be extremely difficult and costly to do those kind of studies. But the field has been trying to do some of those studies, like the Stampede that we did in Cleveland Clinic back in the day, 15 years ago. So those people who had obesity and type 2 diabetes, and then they were randomized to the bariatric surgery, gastric bypass, or sleeve, or the best available medical treatment for diabetes at the time, which was not semaglutide or tirzepatide, but they're best available at that time, 12 years ago, 15 years ago. And it showed that surgery outperformed the medication. So still those study can be done, but it's extremely challenging. So you may ask why we have all this extensive literature and studies coming out every week on the GLP-1s, but we don't have that for surgery. That's the main reason. It's not easy to randomize people for surgery or medication. But yeah, I mean, there are some studies coming out in the progress, specifically for liver disease or for obesity or for diabetes. So it's going to take few years to have their data, but there are some studies in progress as far as I know. Kathy, do you want to add more?
Yeah, I think you've really hit the nail on the head. Designing these studies, recruiting for them is challenging, to put it very mildly. I do think that Dr. Lake highlighted something in the chat which is important, which is that here, headed actually by Dr. Lake, Dr. Minion, we are recruiting for the Flames RCT, which is indeed a comparison of idealized sort of medical therapy versus bariatric surgery in those with advanced MASH, cirrhosis. And that is actually a trial that is a direct, in some ways, head-to-head, looking at those two arms that we are actively recruiting for. But we have run into all of the issues and more that Dr. Minion already kind of expressed just now. And I think the other issue, and I do see another question perhaps here about coverage for screening. And Ellen, if you're able to maybe just clarify what screening you're asking about. But I think coverage for many of these medications, which I did not address in my talk, is a major barrier. I think everyone on the line is aware that, especially in the US, insurance coverage is pretty poor at times for GLPs in the absence of type 2 diabetes. So the weight loss GLPs I made a point about. So, for example, for the Flames RCT that Dr. Lake mentioned, that one we're trying to get medications through patients' insurance, and that is a huge limiting factor to their care. So I'll end with that.
Thank you. Just to piggyback on some of the questions that are coming up regarding screening for MASLD and how do we identify appropriately at-risk MASH patients? So I'd be curious to hear from the panel how our endocrinology colleagues, primary care colleagues, kind of what has been your experience with screening strategies, both in terms of access, but then also in understanding the interpretation and how this has been incorporated into non-hepatology guidelines or guidances.
I'm happy to take this one if you would like, Dr. Like. So we have been doing a lot of work on creating an algorithm for screening patients at risk. Essentially, what I do in my clinic, in my obesity and diabetes clinic, is I screen most of my patients, if not all of my patients, because all of my patients that are high risk, if they have obesity, diabetes, hypertriglyceridemia, hypertension, a lot of metabolic risk factors. And what I do is I use the FIB4 screening tool, which is incorporated into our Epic. I'm sure it's incorporated into a lot of the participants' electronic health system, but if it's not incorporated, it is free to use online. If you search FIB4, you can access that tool. And then based on that risk, what we generally do here is we order a FibroScan or a VCTE, and I have not had any challenges with getting that covered. And of course, we're very fortunate to be able to access FibroScans in our institution.
Thank you. So just to follow up on that question, typically when, as non-hepatology providers, when you do get these, transient elastography or, FibroScan reports, how comfortable are you navigating the interpretation? Or if not at all, or is that something, you're looking towards? And if you don't have FibroScan available, are there other, biochemical NITs or imaging-based testing like MR elastography or ultrasound elastography that you might leverage?
I think there is, frankly, a little bit of a level of discomfort that exists among endocrinologists and primary care providers, and also the issue of time. We only have a certain amount of time and that we can dedicate to a patient in a specific visit, and there's a lot of issues we're often trying to address. So something like the question whether or not they should be screened for MASLD, MASH, fibrosis, often, unfortunately, falls by the wayside. However, when it comes to mind, and I would argue that, as Dr. Maurer mentioned earlier, the FIB4 is probably our go-to screening tool for many people. When we put in for that ultrasound or that FibroScan, I do think that, if the result is just showing kind of MASLD with no evidence of fibrosis, yet a lot of people are comfortable doing metabolic management on those individuals. I think it's when we start to progress into fibrosis, and I see a question here about Rezdiffra, and I'll perhaps let you tackle that in a second, but that's when I feel that many endocrinologists and internists will start to push that individual in the direction of a hepatologist for optimized care. And I think, recognizing that that's not always possible everywhere. So we're very fortunate here.
And then we'll take our last question from the chat on Rezdiffra. I'm going to assume that what that question is elucidating to is, case identification and what are appropriate patients for that. Absolutely have to acknowledge that we've been very fortunate in the MASH landscape to finally now have an FDA-approved therapy in the form of resmetirom. That's been a massive game changer in the field because it was the first, drug that even went on to get, accelerated approval because it finally met the co-primary endpoint of not just MASH resolution, but also fibrosis regression. A lot of the nuances and challenges that we have to navigate in terms of insurance coverage are often pertaining to demonstrating that patients do have what we would consider stage 2 or stage 3 fibrosis. Every insurance company has different nuances. And so whether that's through liver biopsy or a combination of what we call non-invasive testing, access for the medication has rapidly evolved, whereby we'd say, if a patient meets criteria for about 80 to 90% of that, we are able to get covered. However, it is also important to remember that for most of these patients, Rezdiffra or resmetirom is very much a liver-directed therapy, but it's absolutely imperative to also address their underlying cardiometabolic dysfunction, right? So leveraging your, endocrinologist to help address the underlying of what we call diabesity is absolutely pivotal to ensure adequate disease control and if not regression over time. Right. So with that, everyone, we're going to move on to our case discussions for the evening. The first case we're going to be discussing this evening is of a 57-year-old female who has class 3 obesity with an initial BMI of around 57. She's pre-diabetes, hypertension, dyslipidemia, sleep apnea, on CPAP, and has developed, and she comes to our hepatology clinic now with compensated MASH-related cirrhosis with evidence of what we would consider clinically significant portal hypertension. And the way this is defined clinically is because when she went in, because she met Baveno criteria for variceal screening, on her upper endoscopy, she was in fact found to have small varices with evidence of portal hypertensive gastropathy as well. So the conversations obviously that were had with this patient in clinic was that it is imperative that she addresses her underlying obesity as part of decompensation prophylaxis. So this patient's primary care had already initiated her on semaglutide. However, the max tolerated dose for her was only 1.7 milligrams over 6 months, through which she achieved 6% total body weight loss. She was then eventually transitioned to tirzepatide and was only able to tolerate that up to 7.5 milligrams for about 4 months, cumulatively, achieving about 8.4% total body weight loss. So she's now at a BMI about 52. Obviously, through this, she comes back for her routine cirrhosis care and has a repeat upper endoscopy given concern for disease progression. And now on her EGD, she has evidence of large, granted non-bleeding varices and undergoes variceal ligation. She's also reporting recent onset lower extremity edema and is initiated on furosemide and low dose spironolactone as well. So looking at this patient, she's now inquiring about what she can really do to optimize things to prevent hepatic decompensation, because she's very, very keen on not having to proceed with a liver transplant down the line, given her mother having had a very difficult course and needing a simultaneous liver kidney transplant. So I guess I'm going to put this out to the panel that looking at this patient now, what are some of the treatment strategies that you would consider for her for metabolic optimization as part of preventing decompensation?
I guess I'm going to start first. I mean, I wish that patient was referred 15 years earlier to our center to be considered for bariatric surgery before getting to cirrhosis and portal hypertension. But still, I mean, you may feel it's too late, but it's not. You still can help patients still with the BMI of 57. You tried, or the team tried to help them with the medication. Patient didn't respond that she hoped for or the team hoped for, but still the metabolic surgery can be an option. But we discussed that patient has portal hypertension. If we take the patient to the OR, Dr. Navarrete take the patient to the OR and fire the stapler, it may cause profuse bleeding. So that's our protocol that Dr. Navarrete can explain more. But we're going to send the patient with your help, with the hepatology help and the multidisciplinary conversation and discussion. We're going to refer the patient to the interventional radiologist. They place the tips, lower the portal pressure, and then we confirm disappearance of those varices and portal hypertension, then the sleeve gastrectomy would be a good choice. Hopefully going to help a patient. And as we discussed, everything starts with obesity and still can be to some extent reversible. And if we take care of patient excess weight, we not only help with the NASH or cirrhosis, we're going to help with pre-diabetes and high blood pressure and hyperlipidemia and sleep apnea. All those are related to the excess weight, and all those, when we tackle the root cause of those, that's going to improve patient health overall and going to improve patient quality of life. But I'm gonna hand it over to Dr. Navarrete to build based on that. Sal, do you have anything else to add? You are extremely experienced in taking care of these patients.
No, I think you touched the more important thing. One is we try to help those patients, and we saw some progression on the portal hypertension, even losing losing some weight. But the more important thing is to address this pre-op and then get this patient through the tips, so you minimize the risk of bleeding during the procedure. And then in the second case, we can comment a little bit on what we do, when we do it at the same time with the transplant.
Thank you
If I
both.
If I just may make one comment here, I think looking at the BMI, it's pretty apparent that if this patient can be optimized for a bariatric approach, that would certainly be the preferred modality. I would offer, however, that I see this comment about max tolerated dose next to tirzepatide, and this raises some questions in my mind. So what exactly do we mean by max tolerated, and have we truly done our due diligence in trying to do symptom mitigation for a said patient to achieve higher doses of the medication? I displayed some data earlier showing, even from a MASH standpoint, higher doses of tirzepatide seems to be preferable. So I think that just recognizing there is a place here as well, again, thinking that multidisciplinary approach for individuals who have experience utilizing these medications and mitigating side effects, coaching patients through nutritional changes to mitigate side effects on the medications, to do that. So just one last thought there.
So thank you for picking that up, because we unfortunately see that quite a bit. Dr. Maurer, what has your experience been, navigating these conversations with patients when they say, well, the GI side effects were just untenable for me to continue?
Yes, I actually want to echo very much what Dr. Zoe said. I was about to say the exact same thing. I see it all the time. And very frequently, actually, I get patients who come to me not having tolerated, and I do get them to tolerate higher doses. There are many, many strategies. Sometimes titration needs to be slowed down. Some patients cannot escalate dose every 4 weeks, just like as recommended. Some patients need slower titrations, dietary modifications. Sometimes patients tell me I'm very bloated with the medications and they're drinking a ton of soda, ton of carbonated drinks. Just cutting down on that improves the GI symptoms. So there's a lot of different things. A lot of patients with diarrhea, fiber supplements like Metamucil can improve that, and same goes with constipation. These medications not only decrease appetite, but they also decrease thirst. So a lot of patients are not consuming enough fluids and they're having a lot of constipation. So just increasing the fluids, measuring their fluids can improve tolerability. Again, I echo that this patient probably is a good surgical candidate, in not to replace the surgical option, but in addition, I think it perhaps is too premature for us to say whether the patient tolerated it or not without getting a little bit more context. And of course, we have not talked about lifestyle modifications today, but that's another thing that we haven't talked about. Is this patient exercising? Is this patient eating healthy? Certainly, I'm not naive enough to think that lifestyle modifications will bring this patient to a healthy weight, but certainly it's an important piece of the puzzle that we can't forget about.
Very well said. So this patient did end up proceeding with, as our surgical colleagues mentioned, a preoperative TIPS with then an interval laparoscopic sleeve gastrectomy. So just a quick overview of kind of what our process is. Usually these patients will require an extensive preoperative evaluation, and a big part of that is getting a good quality cardiac assessment, really doing a good echocardiogram, looking at their RV function, making sure that they don't have any degree of heart failure, valvular abnormalities, arrhythmias that might be prohibitive. Because when we do proceed with a TIPS, which is a transjugular intrahepatic portosystemic shunt, to decompress the portovenous system, we have to make sure that the right side of the heart will be able to handle that preload. So this patient, when they did proceed with TIPS, their portosystemic gradient was at 15, which very much explains the large varices, and with the stent was brought down to 7. We then did confirmed, stent patency with an ultrasound, and then a follow-up upper endoscopy confirming variceal resolution. I'd like to throw this out to Dr. Aminian and Dr. Navarrete to speak to a little bit about some of the intraoperative considerations that you have for patients like this. Or what are some of the surgical nuances you have to keep in mind when, comparing this to an individual who doesn't have underlying cirrhosis with portal hypertension?
Dan, you want to take it?
Yeah. So I think, as we mentioned, we need to be careful in these patients because, the veins after the portal hypertension, they get dilated and they're bigger. So, on top of the energy devices that we use, we also use some mechanical devices like clips or hemologs to help ligating every vessel. And then another important point is we have to feel how thickened the stomach is because you have to adapt the size of the stapler as well. Sometimes these patients have thicker stomach, they're a little bit more edematous, so you have to, use bigger staplers and then reinforce either with suture, with reinforcement to the staplers, and you have to do as much as we can to minimize the risks. And of course, you confirm that everything is okay with an endoscopy. But definitely, what makes a huge difference, especially in these patients with portal hypertension, is the pre-op tips.
Thank you. So with that, we're going to move on. Well, just this patient actually did pretty well, ended up losing nearly 30% of their total body weight, and had no issues in terms of post-operative hepatic decompensation. Right. Moving on to our next case, I think it's really important to also have conversations surrounding how we navigate our patients who do progress to decompensated MASH cirrhosis and still have uncontrolled diabetes, and are proceeding with liver transplantation. So a lot of what has happened in the past decade is emergence of this technique of concurrent liver transplant and metabolic surgery, which we've adopted at the Cleveland Clinic as well. And so, Dr. Khalid, I know you're with us as well. And what I want to ask you is, when you have a patient like this, a 61-year-old female who's here with decompensated cirrhosis, and she's got, class 3 obesity with a BMI of 54, uncontrolled diabetes, insulin dependent, going into transplant, what is your criteria when determining eligibility for concurrent sleep at the time of transplant for these patients? Or what is your selection criteria that you'd be looking for?
Yeah, thank you, Sylvia. So some things that we consider, the way I see this patient is I divide these factors into 3 groups. One are social, that, out of my control, insurance and all these kind of things. The other 2 factors that I pay attention to is, one is anatomical, second is physiologic. So things to be considerate of, as Dr. Aminian and Dr. Navrat mentioned, these doing sleeve gastrectomies on these patients are a bit more tricky, a bit more challenging, needs a little bit more nuance. So their degree of portal hypertension, but more importantly, their distribution of portal hypertension. So let's say most of their varices are distributed in a perigastric, perisplenic area, which will make a sleeve gastrectomy more dangerous or prone to blood loss. Perhaps those are not ideal patients. Similarly, another thing to pay attention to is the physiology of patients. So not immediately after transplant, you will see a resolution of portal hypertension. They'll still be coagulopathic. The vessels will still have, quite dilated. They'll still have significant pressure in them. So plus, if they have any other organ dysfunction, let's say a patient needs a simultaneous kidney transplant or a heart transplant or a lung transplant or getting another, cardiac procedures done. So an added time and added physiology, or let's say they're on tons of pressors going into transplant, I think those are the patients I consider less optimal for sleeve gastrectomy patients. But generally speaking, overwhelming majority of the patients who had failed medical management or of obesity and cannot wait to get a preoperative treatment for their obesity done, I think it offers a great opportunity for us to correct their obesity at the same time. And our group has we learned together, and we were able to accomplish very safe and good outcomes in high-risk patients. So I think as we're learning, a lot of these factors that I mentioned may become thing of past. So I think as we learn and gain more experience, I think a lot of these factors will become secondary, and I think we'll be able to offer them to most of our patients who cannot get preoperative obesity management.
Thank you so much. So as a follow-up to that, do you have any particular considerations in terms of the graft? So, I mean, I know you talked about the degree of what we consider acute on chronic liver failure, say, before considering these patients. But what about the graft type? Like, do you lean more towards deceased donors or doing this in patients who are more stable and would be candidates for living donor transplantation?
So for now, again, I think it's more of an experience thing. So currently we're using only for, deceased donor transplants. But I think down the line, an ideal patient for getting a sleeve gastrectomy, a simultaneous sleeve gastrectomy with liver transplant, is a patient who has relatively moderate degree of portal hypertension, where the patient's physiology can tolerate a long, multiple operations. So a living donor is going to be an ideal operation down the line. I think right now it is more of a volume thing than anything else. But I think, and I know certain centers do offer that kind of operation where they do living donors and sleeve gastrectomies together. And just by looking at the physiology, I think most of these patients are actually ideal patients. They're relatively lower MELD and, in a relatively, decent health when it comes to, other multi-organ dysfunction. So I think that is going to be an area that is going to evolve, and that is going to become a mainstream indication for these combined procedures.
Absolutely. Okay. So again, this is, for the panel, but generally with these patients who've, say, undergone concurrent, sleeve at the time of transplant, what post-op or, concerns would you have or you would want to ensure you mitigate or anticipate for them to ensure that they have a successful outcome? So how would you manage them differently from a patient who's just having a liver transplant?
So I think the most important consideration post-operatively in these patients with sleeve gastrectomy is the risk of acute kidney injury. So sleeve gastrectomy in itself does not add a risk for acute kidney injury per se, and there's good data to support it. But the risk of acute kidney injury post-liver transplant is quite substantial, upwards of 50%, and patients requiring renal replacement therapy in upwards of 20%. So there is a substantial group of patients that develop kidney dysfunction post-transplant. Part of it is, the operation itself. Part of it is, induction of immune suppression post-transplant that is associated with kidney dysfunction. So an additional problem on top of it becomes, or we have to be considerate of, is the nutritional status of these patients. So early post-transplant, it's a learning curve, and as we're doing more, we're learning and we're getting better at it. Is the proper hydration and ensuring we do not lead to an additional insult on top of immune suppressive medication that we are using. And so I think this is something to be something to consider, and that's why one of the reasons that I think we haven't quite started doing simultaneous liver and kidneys and sleeve gastrectomies in those patients. But I think as we are getting better at managing fluid status and nutritional status post transplant in these combined procedures, I think they will become a part of this protocol as well.
Absolutely, Dr. Navarrete.
Yeah, I want to make a couple comments. One is, the main question is why not doing this after the liver, right? And the patients are better and the liver function is recovered. And what we're trying to do is to protect that graft, right? Because the underlying disease is still there, right? The metabolic problem hasn't been solved. And then we know that, with the bariatric procedure, we're really assessing that. We also know from prior data that the average from the moment that you put the new liver to these patients can get a bariatric surgery go to 18 months to 2 years. So that put those patients, that graft is gonna be suffering during that time. Then you're looking at a patient that is going to have a big operation before, like a big laparotomy, scar tissue. So that's going to make it way difficult. So those are the two main reasons why we started doing this based on the original Mayo experience, because it's important to say their data just got published this year. with 72 patients done in three different centers compared to 180 of patients with transplant, obese patients with transplant without the sleeve. And once we're in there, of course, the priority is the graft. Once the liver is there, and then the flow is good, and then the patient is compensated, it's not coagulopathic, and then we decide, okay, it's safe now to do the sleeve. And as the panelists were saying, these patients are a little bit more different in terms of the tolerance of the PO intake, and that's something that we've learned in the first one or two cases. We were a little bit aggressive in terms of the size of the sleeve, like the same that we do for normal patients. So we've learned in these patients we cannot be like that because the stomach is thicker. They're going to be on the anti-rejection medication. So these patients are more nauseous than a usual patient. Some of them will need enteral feeds for 3 or 4 weeks until we get out of that period or that window where they're more susceptible to develop the CKD. And that's something that we've been, learning. In this particular patient, she did spectacular. I mean, she didn't have any problems at all. The weight loss is fantastic, 207 pounds. It's, more than you expect with the sleeve. Of course, these patients have some, fluid overload at the moment of the transplant. So not all of this, weight that they lose, it's related to the obesity per se. But, definitely we have to adjust a few things technically, and of course, considering evaluate this patient soon enough so we can implement enteral feeds if we need to prevent the kidney damage.
Absolutely. No, thank you, both of you. And as the transplant hepatologist in the group, the unfortunate rise of what we now consider post-transplant MASH, recurrent MASH or even de novo MASH is just substantially, going through the roof, as particularly our median age for transplant just keeps getting younger. And so with that, that is the end of our cases. I just want to...
Sylvia, can I have one quick comment? So we should not stop treating obesity. I think that should be the take-home message. We should not stop treating obesity. People with MASH, people with fibrotic MASH, people with cirrhosis, people with compensated cirrhosis or decompensated cirrhosis before transplant, concurrent with transplant, after transplant, to protect the transplanted liver. We can help by treating the obesity to improve patient health, and that can be with the medications, with lifestyle, with bariatric surgery, combination of both. But I think the take-home message is that we should not stop treating obesity in these patients. Thank you.
Very well said. And that was actually the perfect closing statement. I just want to thank the phenomenal panel we had today. This was such a great session, and admittedly, an hour 15 is definitely not enough to cover all of it. I want to thank the audience for joining us, and the active participation and the questions in the chat were phenomenal. Just to highlight some of the other sessions upcoming in our series, our next Cleveland Clinic live session is going to be on July 9th, looking at personalized approaches to neoadjuvant therapy in rectal cancer, which will be led by our multidisciplinary colorectal team. Once again, thank you everyone for joining, and for any further educational programming, to visit our website.